Yeah, great.
So thank you the team for invitations. I'm Dr. Bancha from Thailand and my fellows Dr. Arrisna Artha from Indonesia. Thank you Arrisna for making this video for me. Okay, so I'm talking about the osteochondritis dissecans of the knee. The new technique of fixation we call the suture anchor fixation. So I show you the patient. This is the 25 years old male. He had the knee pain and locking. If you look from the x-ray, you can see that on the medial femoral condyle, there's a big piece of bone. You see that? You can zoom in and you can see lateral view. This is quite big piece of bone, right? For measuring, it's nearly 2 centimeters. So we also do the MRI study. Okay. So he has knee pain and also has the locking. So that's a big piece of bone and it's also unstable. This piece is floating. So we did the arthroscopic examination first. Okay, when we get in the jaw, you can see that there's a big defect, okay, on the medial femoral condyle. And this is the old defect. Okay. So first we clean the soft tissues, we clean the fat pad for better exposure. And this piece is floating. But it's still attached to the PCL, okay? Because OCD is always close to the PCL. First, I make a good raw surface on the defect using the microfracture, using the KY to drill, and also use a curettage, okay, to make a good raw surface. Because this is a chronic case, okay, to make a good bleeding. And also the shaver. Can we make like as much as possible? It's about 3-4 millimeters apart, okay, for this the subchondral, because we want to promote the healing potential. Okay, then we measure the size. It's about 1.5, okay, by 2 centimeters, okay, quite big lesion on the weight bearing area of the medial femoral condyle. So after that, we try to reduce this piece of bone back. You can see that you still have this soft tissue attachment. This is a PCL, okay, and I try to match, okay, put this back. This is a PCL that attach. So we make 3 portals, 2 and another portal is in the center, okay. So we try to reduce it back, okay, and then we use a suture hook, okay, to repair this piece to the PCL, okay, like that way. So this suture is running underneath the fragment to the PCL, okay. We make a big bite to the PCL, but make sure that you're not going to the ACL also, just the PCL, okay. And after that, we use the suture anchor. You see that this is a suture anchor. It's the double load suture fix, okay, the small one, the one that we do bank cut, okay, same one. And this is double load, okay. So the trick is we put this opposite side, far away from the PCL. So our goal is to pass the suture around the fragment into the PCL, okay, and then we fix it like a foot suture bridge, okay. Then we retrieve the suture one by one, okay, using the accessory portal, then pass the suture underneath the fragment into the PCL, okay. That's the first one. And then the tiger one did it the same way, okay, go around the fragment, okay, and then retrieve it. We didn't use the cannula, we just used the small hose, no cannula. So the benefit of this technique is that you have no injury on the cartilage. Okay, because any fixation that go through that, this is the percutaneous. We use it temporarily to make it stable. Okay, after you loop around that PCL, then we tie the knot. Okay, like that way. Okay, stabilize to the PCL like that way. So after that, we remove the KY. Okay, cut the sutures. Okay, after that, we check the stability. Yeah, bend the knee, extend the knee. It's stable enough, okay, to stay there. And also, I put the patient in the cast in full extension, because in full extension, I think there will be compression force, okay, onto this fragment by the tibia. So that's the compress this fragment into the crater, because this is a weight bearing area. So if I immobilize the patient in the cast full extension for 3 weeks and then let the patient move. Okay, I think this is the very important point, because you are allowed to have the compression load and let the patient walk, can put the weight on. Okay, because we need compression force to this fragment. And this is after the surgery, about 3 months. You see the fragment heal nicely. Okay, so that's the one of this technique is going to publish in arthroscopy technique. Okay, I think this technique is minimal invasive and you have no injury to the cartilage, and this is works very well. Okay, so thank you.